Good afternoon and welcome everybody to the fourth in our series of conversations on the future of public safety, sponsored by John Jay College of Criminal Justice and the National Organization of Black Law Enforcement Executives. My name is James Cadogan and I'm very privileged to be the moderator for this series, and especially looking forward to today's conversation where we are focusing on public health and public welfare. The past three conversations we have had have really elevated the idea of an ecosystem when it comes to public safety. And so many of our prior panelists have keyed in on the idea of public health as a critical driver of public safety and a critical element of our policy making that goes undersung in our decision making and discussions about how we get from where we are now, this moment of reckoning on racial justice and policing practices, to the new public safety that we want to create together. So I am particularly pleased to be able to introduce today 5 distinguished medical health professionals who are experts in their field and will be joining us to talk about public safety, public health, and public welfare in the context of how we move forward from here to the future that we want to create together. First up in those introductions is Dr. Nadine Gracia, who is the Executive Vice President and COO at Trust for America's Health. Welcome, Dr. Gracia.
Thank you. Good afternoon, James. It's wonderful to be with you.
We also have Dr. Thomas LaVeist. He is the Dean and Weatherhead Presidential Chair in Health Equity at Tulane University's School of Public Health. Welcome, Dr. LaVeist.
Thank you for having me. It's a pleasure.
We have Dr. Cassandra Crifasi, Assistant Professor in the Department of Health Policy and Management at Johns Hopkins School of Public Health. She is also the Deputy Director for the Center of Gun Policy and Research. Welcome, Dr. Crifasi.
Thank you.
We have Dr. Marc Zimmerman, Director of the Prevention Research Center of Michigan and the Director of the Youth Violence Prevention Center. Welcome.
Thank you very much. Appreciate being here.
And finally, we have Dr. Howard Spivak, the former Principal Deputy Director at the National Institute of Justice. Welcome, Dr. Spivak.
Hi, James. It's great to be here.
Great to see you. So I couldn't be happier to have all of you here to follow up on the dialogues that we've been having over the course of the past 2 weeks. And really, I want to start with definitions, as we've done before, but this is a little bit different. We've talked about how policing is just one dimension of public safety, and we want to have this conversation holistically. So when it comes to public safety and public health, how would you actually define public health in the context of public safety? And how do you define the relationship between public health and public safety? That's a question that we want to try to answer throughout this conversation. But I'm going to pose that first to Dr. Gracia, Dr. Crifasi, and Dr. Spivak to see if you can tell us how you define that relationship and help us level set for this discussion. Dr. Gracia first, if you would, please.
Certainly. Well, thank you again. And it's really great to join all of these panelists for this important conversation. Public health and public safety are really integrally linked. You can think of public health from the standpoint of really wanting to ensure the conditions in which everyone has the opportunity to live healthy lives and thrive. And so healthy communities really can help to create safe communities. You think about that in terms of the conditions, for example, of being able to live in a safe community, have walkable and bikeable paths that are safe, to have access to the types of resources that you need to feel that you are safe and connected to other residents, neighborhood residents in your community, and to ensure that there is a sense of cohesion in community. So it's not dissecting one from the other, but really recognizing that building and having safe and healthy communities really is an integral part of overall public safety.
It's a great way to start. The idea that we are able to thrive as individuals and as communities, have a sense of cohesion to bring about safety and health. That's so very important. Coming to Dr. Crifasi, if you could.
Yeah, I just want to start off by echoing what Dr. Gracia said. There is such an intertwining of public safety and public health. You cannot have healthy communities that aren't safe, and you can't have safe communities that aren't healthy. And so we really need to be thinking about this in a holistic approach. When I think about the relationship between these two, one of the challenges we have moving forward is that for too long, problems that have impacted white communities have been thought of as social problems or public health problems. But when those very same problems impact communities of color, we take a policing approach, really coming at it more from the public safety side of things. And I think that has led to generations of communities where they are not receiving the public health services that they need. And I'm just really excited to be part of this conversation so that we can do a better job of acknowledging the integral link between public safety and public health.
Thanks so much. The idea that you can't have a safe community that's not healthy or a healthy community that's not safe is a brilliant way of putting it. And when it comes to racial disparities or thinking about the difference between deploying public health interventions and services versus policing, that's a lot of what we want to dig into today. So I appreciate that as a preface. Dr. Spivak, please.
Yeah, in addition to agreeing what's been said before, I'd like to bring another dimension into this, and that is what we know about the impact of the absence of safety and the feeling of not being safe. And there's some incredibly strong science that shows that has huge impact on both the emotional and physical health of individuals. We know it in children who experience early trauma in their lives, and it actually causes neurological and biological changes in those children that increase their risk for mental health problems and for chronic disease such as cancer and heart disease. We also see that in studies of women who have experienced intimate partner violence or sexual violence, who also have higher rates of both mental illness and cancer and heart disease and other chronic illnesses. So it's not just that safety is important for good health, but the absence of safety actually creates ill health and increase health risk considerably.
You packed a lot in there, Dr. Spivak. I just want to recap briefly, thinking about the absence of safety and the science on the absence of safety and the impact that has on the physical and mental and emotional health, the science on trauma, and then juvenile impacts in particular, and women who have experienced intimate partner violence. These are all critical elements of our public safety dialogue that we haven't yet unearthed or raised to the level of other parts of that dialogue. So I'm so appreciative that you brought all of that up. I want to put a pin in some of those for our further conversation as we go forward. I want to dig a little more into disparities and bring in Dr. LaVeist, Dr. Zimmerman, to pick up on something that Dr. Crifasi noted about racial disparities in deploying resources in the public safety context and public health. Right now, we have an outcry from Black, Brown, and Indigenous communities to do something different when it comes to public safety and to change from an incarceration and a policing mindset to a service and a public health orientation and mindset. Can you talk to us about some of the baselines for this? So for our viewing audience, we can start to understand some of the racial disparities in delivery of public health services and outcomes. I think that's a really important element for us to set on the map of this conversation.
Yeah, I think it's critical to this conversation to consider that the United States is a dramatically racially segregated society. So that although we live in the country together, we experience the country in very different ways, largely on the basis of our geography, where we live. So many communities in this country that are predominantly African American are communities that are geographically isolated into communities that do not have an infrastructure that produces good public health or good health outcomes for people. Things like food environment that does not produce good health outcomes. Quality of housing is not what it needs to be. It doesn't have an economy that allows people, especially young people, to get that first step on the rung, on the ladder towards economic development. Quality of the schools are not as good as they should be. So since we haven't invested in providing the infrastructure that would produce the good health outcomes in these communities, this then leaves people with fewer options for lifestyle. And what we've done instead is that we've invested in overly policing these communities. So not only are we devoid of the resources necessary to produce good health outcomes, but then you have a strong presence of militarized police that's been deployed to try to address the social problems that evolve as a result of that lack of infrastructure. So there's an inextricable link here between public safety and public health.
Thank you so much, Dr. LaVeist. The idea of that infrastructure being critical to how we begin to deliver what is needed to communities to meet community needs is so important. And we're going to dig much further into that idea of investment, because that's been such an important part of the discussion right now about policing and where we go from here. Dr. Zimmerman, if I could get you in here, please.
Sure. David Hatcher, in speaking about firearms in particular, said if it's not a health issue, why are people dying from it? Similarly, around violence, is just in general, violence is very much a public health problem. I think violence is where we kind of have arguments for why we need to have armed police. But I find it really interesting that we have, we're talking about public safety. And when we do that, we talk about the police. It's almost a euphemism for police. And if you think about safety, then why do they need guns? And where is the whole idea about how firearms are seen as a way to make us safe, when in fact a lot of research has been done to show that having a gun, you're actually more likely to be hurt by that firearm than you are to protect yourself. Individual stories notwithstanding, in general, that's basically the case. The other issues, things like 15-year-old is 14 times more likely to die of homicide if you're Black than if you're white, in terms of a disparity. That certainly isn't a result of just race, or just there's lots of other factors, socioeconomic and redlining. Some of the things that Dr. LaVeist was talking about are behind that. When we think about the idea that violence and safety has been in the realm of law enforcement, and not thinking about it in the realm of public health, is almost misguided, because as Dr. Spivak mentioned, some of my own research, we've found that exposure to violence in adolescence relates to cardiovascular disease, and by the time you're 30 years old, we found that women are reporting more positive pap smears who've been exposed to violence as adolescents. And so it's pretty clear that violence exposure is a public health problem. And when we think about public safety, if we think about that more broadly, what are the roles that we can play in terms of prevention, in terms of applying some of the public health science of epidemiology and root causes, and thinking about that versus simply a policing matter.
A health issue, then why are people dying from it? That's a great quote. And on the question of violence, I think we want to dig in on this a lot more, because violence and violence prevention in professional circles now, we're starting to have the conversations that really elevate the research that all of you have spent so much of your careers on. I'd like to bring in Dr. Gracia, Dr. Crifasi, and Dr. Spivak, if we can. Can you talk to us about the relationship between public health and violence, and public health interventions and violence reduction? It's a big topic, but I think just to introduce us to how we should start to think about public health as a violence interrupter would be really helpful. Dr. Spivak, if you could first.
Well, there's a couple of things I'd like to say. One is there has been some incredibly good work done looking at the role of community workers in working with people at a community level in interrupting sequences that lead to violent behavior. But I think it's even more complex than that, and it's more important to think about a really broad, holistic approach to this, where public health is not a single discipline. Public health is many disciplines working together. And in fact, good community-based violence prevention is not a single agency or a single sector doing something. It's many sectors coming together and defining their individual roles in a bigger picture. And a lot of the work, for example, that we did in Boston several decades ago now, actually, involved literally several hundred agencies in the city both large public agencies as well as smaller community agencies working together, identifying youth who are in trouble, but also creating a shift in thinking and in the environment around how people are supported and seen at the community level.
Public health as multiple disciplines working together. This feels like a theme that we've come back to time and again throughout our conversations on public safety, that we have this narrow conception of public safety, that it's one thing, that it's policing, that it's maybe jails and prisons, but there's so much more that's in the ecosystem of creating a healthy community. That is a thought that clearly lingers with us and that we need to emphasize and unpack even more. Dr. Gracia, please.
Yes, if I could build on that, Dr. Spivak made the important point about how this isn't just one sector. And when we talk about health, and I'll also underscore what Dr. LaVeist noted earlier about the factors that actually influence health, that it's importantly housing, education, access to quality food, that it's importantly also the relationships and partnerships of access to community services, access to transportation. All of those are drivers of health, in addition to factors such as access, for example, to health insurance coverage and access to health care. But we know from studies that actually it's those broader social determinants of health, such as where you live, where you learn, where you work, where you play, that actually have an even greater significance on your health and well-being. And everyone is impacted by their social determinants of health. But what we see, for example, in particular with communities of color, are there inequities that exist in those determinants, within those structural drivers. And so when we think about addressing violence, and violence certainly being a public health issue, it really does require that type of a holistic approach, bringing together multiple sectors, not only to intervene, which is an important point, but also looking at how we move further upstream to actually address prevention. And Dr. Spivak talked about, for example, the trauma and adverse experiences that can happen in childhood. It's how do we look at systems across education and housing and justice and other areas to be able to actually promote equitable conditions, policies, and programs that are actually going to allow children to be able to reach their full potential and thrive. And so when we think about violence prevention, using a public health framework really is one that is going to address those underlying structural drivers of health and well-being.
The structural drivers of health and well-being being multi-sectoral and cross-system. That's really helpful. Dr. Crifasi, if I can come to you.
Yeah, again, I just want to build off of what Dr. Spivak and Dr. Gracia have said. Social determinants of health are so important when we're thinking about violence prevention. Unfortunately, in communities that experience disproportionately high rates of gun violence, they often, these important social determinants, there may be limited access or low quality, or some of these resources for these social determinants are just non-existent. And this has led to individuals in many of these impacted communities learning that in order to meet their basic needs, food, clothing, shelter, those sorts of things, gainful employment, they will use violence as a tool to meet those ends, not necessarily because they are individuals who want to hurt people or want to engage in violence, but they have no other mechanism to meet their basic needs for themselves or for their families. We've tried and failed to arrest our way out of this problem. And we have mass incarceration as a result, and disenfranchised communities and individuals who are lacking still many basic resources and access to high quality education and employment opportunities. And we really need to ensure that communities are getting those public health benefits, getting the benefit of public health professionals applying the model such that these communities are not just surviving, but they can actually thrive, and the individuals in those communities can become productive members of society.
I love that. And I actually want to stick with you three for just a second to follow up, because part of what we really want to do here is get specific about some of the programming or interventions that each of you in your capacities has seen over time that you think are helpful or that we should be exploring or elevating where they've been successful when it comes to public health and violence prevention, violence interruption, and creating those thriving and healthy communities. But on violence in particular, if I can start with Dr. Spivak, what have you seen and this is in some of the work that I know that you've done before that you think is successful that we should be continued to think about, elevate, and invest in when it comes to violence prevention and public health?
Well, I think one of the basic underlying successes has been the ability in some communities to align services and interconnect services. One of the things we found in Boston was that there were often many agencies serving individual families, but not knowing that the other agencies involved were even involved. So creating communication among agencies, creating a sense of alignment so that agencies are working together and not at cross purposes is extremely important. I think that's one of the elements. I think a second thing is creating partnerships with the police and with the law enforcement system in a different kind of way, where law enforcement is working with other sectors of the community rather than trying to do it all on their own. There were relationships between the police department and the clergy around the city, for example, that greatly improved the ability to work with young people who are getting into trouble and needed more guidance and needed more intervention. The integration and collaboration between mental health services and the police was extremely important. So it's breaking down the silos and having agencies and disciplines and organizations working together rather than trying to fix everything themselves.
That's a perfect encapsulation of so much of what we heard. And in particular, especially when we've had law enforcement panelists, they've stressed how much they cannot do everything by themselves and how they need the support of their counterparts in community organizations and other expert professions to do their jobs together. So I very much appreciate the break the silo effect that we talk about so often in government circles, but haven't done enough of, especially when it comes to public safety. Dr. Gracia, if I could come to you.
Certainly, I think I take two streams. One is, for example, looking at issues of what we often talk about as a school to prison pipeline, and looking at the ability and role, for example, of public health to work with the education sector in addressing issues, for example, of creating safe and supportive school environments where, as was noted earlier, students of color disproportionately face disciplinary measures, whether that's suspensions or expulsions, and really looking at how to create positive school climates that actually don't use disciplinary measures as the first strategy to being able to address issues regarding behavior, issues regarding school performance. It's really setting policies, for example, that actually look at, are there underlying issues that are actually creating a less healthy environment, a less supportive environment for students in schools? Is there bias in the form of teacher education and training, and how they're actually, I should say, bias in the form of how teachers are interacting with students, and in particular, students of color, and implementing training. It's bringing in, for example, mental health services, especially for youth who may have experienced some form of trauma or adverse childhood experience, and seeing in those communities where actually then those disciplinary measures actually are decrease. And we know students who are subjected to, for example, those forms of discipline have a greater risk of becoming involved in the justice system. You can also look at examples, for example, of, and you brought this up earlier, James, with regards to mental health and substance misuse, that we've had very different ways in which issues of substance misuse have been dealt with in this country, where there's been criminalization of, for example, substance misuse in the 80s and 90s, which disproportionately impacted people of color. We now have a more of a public health oriented approach, and you're seeing greater investment, greater partnerships now to address this as a public health issue as opposed to a criminal justice issue. But more needs to be done to ensure that there are not continue to be disparities with regards to access to mental health services. We've seen programs, for example, where you bring together mental health services and law enforcement to be able to either do diversion from justice involvement, to be able to access treatment and services, and therefore then see, for example, a reduction in recidivism, seeing, for example, that when people are returning to their communities and that they have greater opportunity to be able to thrive, as opposed to reverting back to what might be the first thing that happens if they don't have a home, if they don't have a job, that they may then resort to having to engage in this behavior that then gets them right back into the justice system. So where we can actually bring sectors together to be able to address these issues and not, as Dr. Spivak noted, have it in a siloed approach, we see actually greater success.
That's really helpful, and I love the. This is the first time we've talked about school to prison pipeline in this conversation, which is so important, and juvenile justice being so important, and the health components of that, creating the healthy environment that starts young kids and especially Black and brown kids off on the right foot and gives them the support they need to thrive, is something that we absolutely need to elevate. Thank you, Dr. Gracia. Dr. Crifasi.
Yeah. So when we think about public health-based interventions that have been really key to impacting violence, I see the most successful ones as having sort of 5 key components. So they have interruption of violence, right? So violence is contagious and cyclical. And so if you can interrupt violence and start to change social norms about the appropriateness or acceptability of using violence to settle disputes, that can be an active component. As was mentioned by Dr. Gracia and others, there is a lot of historical trauma that individuals in these communities are dealing with. And so making sure that there is mental health services available, cognitive behavioral therapy, helping people change the way they think, right? So we can change their behavior. Job training, so that people can get the skills that they need so that they can achieve gainful employment. Importantly, any program needs to actually deliver the services that it promises. Too often we see public health interventions to reduce violence fail because there are not sufficient resources dedicated to actually providing the participants with the services that they need. And I mean wraparound services, housing, food, all those sorts of things that are necessary for individuals to be able to make a change. And then the final piece that I think is really, really important is that individuals are human. They are going to make mistakes. They may relapse and engage in the kinds of behaviors that we don't want to see. And so programs that allow individuals to make mistakes, but still move through the process, move through the program, are really effective. So for example, ROCA, Advanced Peace in California, or Ready Chicago, these are some programs that really take this holistic approach to improving the life of the individual and the community, and making sure individuals have what they need. And that can really change someone's path and their trajectory and keep them out of violent behaviors.
Out is really useful and thinking about the 5 elements of combating violence. The one that I want to pick up on in particular, and this I would love to get some commentary from Dr. Zimmerman and Dr. LaVeist, is that services actually need to be resourced properly. And this is one of the big discussions that we're now having with respect to public safety and especially policing. The concept of either defund, divest from, or abolish the police is now splashed on headlines throughout the country. And we are having a live political debate about what public safety really means. So in this conversation, as we focus on public health, what Dr. Crifasi just raised, I think is a critical element of our dialogue. If we are considering, and if our policymakers and our elected officials and appointed officials are considering a change to how we apportion our resources, how should we be thinking about resources for public health interventions? And what does that look like in an ideal world? Dr. LaVeist, if I could come to you first.
Yes, I think this is really important. So we talked earlier about this, what I called infrastructure or social determinants, right? So that infrastructure that's required to have a healthy community is the same infrastructure that impacts criminal justice or an unhealthy or violent community, in that the lack of infrastructure produces the violence, right? So it's the fact that we're not investing in these aspects of society that are required for a healthy lifestyle is also what is producing the violence. And this is really a resource allocation issue. I think that the terminology of defunding the police has really been an unfortunate use of a communication strategy, because what it's done is it's allowed some people to use that concept of defunding the police in its most literal sense of saying abolish the existence of police, meaning that no one will be available to answer 911 when the elderly citizen calls in for someone's breaking into their home. And as a result, people have been able to use it in ways that result in resistance to the actual concept, of which is to redirect the resources away from such an overemphasis on criminal justice and more of an emphasis on building out that public health and I would also say social services infrastructure that's necessary to have a healthy community. So I do know in Baltimore, the city that I still live in, Baltimore, that a few years ago, at least, I don't know what the situation is right now, but a few years ago, the budget for overtime for the police was larger than the budget for the health department. And that suggests that the priorities are such that we create the conditions that produce violent communities by not investing in the communities appropriately. And then we have to respond by over-investing in police services. And this is a resource allocation issue for policymakers, but it's also an issue for voters. The fact is that policymakers are put in positions that make it difficult for them to embrace concepts like reallocation of resources, because they then are left within the political realm of having to deal with the political opponents making accusations that they're weak on safety, on public safety, and if voters continue to support the idea of policing with an iron fist. So I think that it's not just the fact that there's not just the police, but it's also an issue for policymakers, and the general public has to embrace the concept that we need to invest more broadly in providing for a healthy community.
You said a lot of great things there, Dr. LaVeist, and in particular thinking about the cycle of failure to invest in healthy communities leading to violence, leading to a response of over-policing, which continues that cycle again and again and again. And the problem of how we break that cycle, in particular with our policymakers and the unelected officials, and trying to combat easily fed narratives about being soft on crime or weak on safety. That's something we clearly have to address, and I'm grateful you raised it. Dr. Zimmerman, if I can get you in here on programs that you've seen that are effective and how we should think about investing our budgets differently.
Yeah, it's really, I agree with everything Dr. LaVeist said. I mean, it's 100% correct. And one of the things that we do is we try to spin the idea on its head a little bit. And when we problematize all the issues that we're trying to deal with, we come up with solutions like militarizing and adding to control, but in public health we think about community engagement. We think about, when we think ecologically, we also think about not only different sectors, but how change in one system might make a change in a different system. We also think about how do we think about things as positively? How do we promote health rather than prevent disease? And if we think about what it takes to promote positive outcomes that we're interested in, save communities, then we might allocate resources in a slightly different way, or maybe a majorly different way. For example, last week, Brittany Packett-Cunningham talked about healthy communities, our living wages, education, good mental health services, some of the themes that are coming up here today. She also mentioned this idea of removing broken windows. So one of the things that I and some other colleagues around the country have been looking at is when you have divestment in communities, you create opportunities for potentially bad behaviors to happen. I suggest to everybody, when you walk around in a big city, Well, what are the streets you walk on? You walk on the streets that have more people on them, the busy streets. You don't walk on the streets where they're abandoned or not very many people. Well, when you have lots of vacancy, we think about, well, what about voiding those and sending police in those places, and those are the hot spots where crime occurs, instead of thinking about how do we address vacancy. So not only does it move us away from thinking about individual behavior change or individual behaviors as the problem, but we start thinking about the environment, and we start thinking about how do we create a busy street rather than how do we fix a broken window. And the idea of breaking of busy streets is cleaning up dumping sites, cleaning up or repurposing empty lots. And researchers in Philadelphia, in your hometown, or it's not your hometown, but where you're now working, Dr. LaVeist, in New Orleans and up in Flint, where we're doing some of this work, we're finding there's fewer police incidents when these kinds of vacant places can be taken back, so to speak, by the community. And by engaging community in the process, there's community ownership and community investment. And it starts from the grassroots at some level. So in terms of, I think in terms of thinking about our resources, we have to think about ways to build up what's positive. And you don't necessarily do that by increasing the number of police. You might do that by investing in the communities and in improving the communities in which we're interested in trying to make more safe.
And the investments that you're talking about are likely to be less expensive than the investments in
Right.
policing.
That's right.
I love that. Promoting health and not preventing disease as a framework for thinking about building community engagement and community buy-in for a renewed sense of public health that aligns with our public safety ideals. Thank you, Dr. Zimmerman. I want to pivot slightly on this, but to talk about interventions for problems of substance use and substance use disorder and mental health, which so often are addressed by police as first responders. A lot of the criminal justice reform and social justice dialogue has been around a need to shift resources and to shift intervention to a public health model for those problems, which is fantastic. But I'd love to come to Dr. Spivak and Dr. Crifasi to talk us through and level set for us when we're thinking about problems of mental health and substance use. How do public health systems and public health professionals try to address those problems? Because I'd like to be able to draw the linkage and some distinction between that and the immediate law enforcement response that right now is customary in most jurisdictions. Dr. Crifasi, if you could.
Yeah, so first I would just say that any law enforcement response to a substance use issue or a mental health, behavioral health issue should be the last resort. But when police are needed, there are some instances where there is a weapon involved or threat of violence, threat of harm to oneself or others. Any interaction that individuals who are having a substance use issue or a mental health issue have with police that really should serve as an entry point into treatment rather than an opportunity to have someone further interact with the criminal justice system. We've spent way too many of our limited resources trying to arrest our way out of the drug problem in this country by focusing on the supply side of the issue, which has gotten us very little in the way of benefits. We have mass incarceration. We have individuals who are separated from their families. We have people who can't find gainful employment because they now have to check a box on an employment application or a housing application. So rather than continuing this approach that has failed us over the last several decades, we need to be focused on the demand side. We need to be taking a public health approach where any interaction is met with an opportunity to be diverted into treatment or services. We need to take a harm reduction approach where we know that there are behaviors that individuals are going to engage in with regard to substance use, for example, but there are ways that we can minimize some of the harms associated with that. And we can meet people where they are. It often takes individuals who have a substance use disorder many, many times seeking treatment before they actually are able to become sober. And if we arrest someone when they're trying to purchase drugs rather than diverting them into treatment, that's a missed opportunity to divert someone into a less expensive and more effective strategy for addressing that issue. With regard to behavioral health, we often know that police get called because there's sort of fear and stigma associated with individuals who are experiencing a behavioral health crisis. And police can arrive and remove the weapon from the situation so that social workers or other mental health providers can then de-escalate and calm the situation. But again, that should be an opportunity to divert individuals into treatment or connect them with resources rather than arresting them. Far too many of our individuals who are in jails have a behavioral health or substance use issue that remain untreated. And so if we really want to address this issue, we need to apply these public health principles and think about intervening with diversion into treatment rather than continuing to put people through the criminal justice system.
A lot into that, which is fantastic. The idea of law enforcement being a last resort. The fact that we can arrest our way out of drug problems, which is so very important, and taking a demand-side approach to diversion treatment services, meeting people where they are with a harm reduction approach that is less expensive and more effective. Less expensive and more effective is an incredibly appealing thing, I imagine, for any policymaker worth their salt. So that framing, I think, is a really good springboard for us. Dr. Spivak, if you could.
Couple of
I think you're
comments
muted.
in addition to agreeing with what's already been said. The first thing is, and I'm not going to get into it because it's a discussion in and of itself, we should be talking more about prevention around mental health disorders and substance abuse as well. And we know a lot about this and what risk factors are that we could be dealing with that would reduce the problem to begin with. But the second issue here is that at this point, a number of years ago, we essentially dismantled the community mental health system in this country. Right. And as a result, we made police the primary responders to mental health and substance abuse disorders. When I've gone to policing conferences, this is one of the biggest issues that comes up all the time, that the police are often put in situations dealing with stuff they're untrained for and really are not the best responders to. And I think this goes back to an earlier question you had in terms of reallocation of resources is part of what we need to look at if we look holistically at the broad issues of creating safe, healthy communities is reinvesting back into the community health system that we dismantled a long time ago and diverting some of those resources in that direction so that the police are, in fact, as was just said, the last resort for dealing with these issues rather than the first responders for dealing with these issues.
Let me just follow up on that because I think this is a really important point. When you said that we essentially dismantled the community mental health infrastructure in this country, can you tell us more about that? Because I think for our listening audience, this is exactly the kind of historical understanding of our policy decisions that bears on where we are now and where we want to go. So we'd love to just get your take on what happened.
I mean, this goes far back. This is not a recent phenomenon. This goes back 30 plus years where we began essentially defunding mental health programs in communities and privatizing the system in a way that greatly limited access. Most insurance programs don't cover mental health services. People are paying out of pocket in a lot of cases. And if you look at the community health center system in this country, there used to be far more extensive mental health services available through that system than are available now. So we took that funding away from them. I wish I understood why. There probably was some thought of reason for that, but it was poor reasoning at the time. And quite frankly, a lot of those resources have ended up going to police departments to deal with a problem they're unqualified and really don't want to be dealing with at all. So we're paying now for decisions that were made decades ago, unfortunately. And this is an issue for everybody, but particularly for communities with limited resources and with high density of poverty.
That is a really helpful look back, and the idea that we have to be thinking in the long term for all of these decisions. And this actually is, it seems like a macro version of Dr. Crifasi, what you said about individuals who experience substance use disorder not necessarily being able to break that cycle and get the treatment that they need, or being successful the first time around. It's a long-term proposition at an individual and a human level, and even longer-term proposition at an institutional and a municipal and a government level to manage public health systems and make decisions that will have those ripple effects over time. So thank you for that look back, Dr. Spivak. I think that's really, really important. Dr. Gracia, if I can come to you on this as well.
Spivak really talked about the dismantling really of the mental health system, and I think that's such an important issue and framing to understand. There's also a fragmentation of the system when you think about the access to services. We know, for example, that communities of color have less access to mental health services. And there's also a fragmentation of services and really a need to further integrate services. It's very difficult to manage seeing providers across different spectrums not being able to have it in a way that it's more integrated and one that is more patient-centric as opposed to facilitating what the system needs to be able to operate. And there are a lot of administrative hurdles to being able to actually have that type of integrated system that both addresses behavioral health needs as well as physical health needs. And then looking at the quality of services, especially when we look at disparities that can exist with regards to access and availability of mental health services, is also ensuring that those services are culturally appropriate, that they're culturally sensitive to the communities. As Crifasi noted, there is stigma that is still associated with mental illness and substance use disorder. And so many who may not want to seek services because of the concern of the stigmatization of mental illness and substance use, but also the sense of treatment, of either feeling there's bias or discrimination in the experience of the treatment and services that are received. I will also want to emphasize, and Dr. Spivak mentioned it and said it could be a whole talk in and of itself, but I think it really is very important, is that whole continuum, that it's important on treatment and recovery, that treatment is effective, recovery is possible, but also moving further upstream to really address prevention. We've talked about trauma, we've talked about adverse childhood experiences. And when you look at the data, adverse childhood experiences, whether it's experiencing abuse or neglect, witnessing violence, having some type of family separation, such as a parent that's incarcerated, it's actually common that over 60% of adults actually have had at least one adverse childhood experience, but it can be prevented. And so when we think about the social and economic conditions that can indeed promote health, having access to a livable wage, living in quality, healthy housing, being able to go to have access to high quality healthcare and access to quality education, those are critical elements when we think about a holistic approach to prevention of trauma, prevention of adverse childhood experiences, and prevention of substance misuse and suicide prevention. And I think we're seeing that really highlighted now in the context of this pandemic, of the COVID-19 pandemic. We're seeing higher rates of anxiety and depression, early preliminary data that are showing higher rates of substance use. These are the issues that we're going to have to grapple with as a nation when we think about really addressing systemic transformation to be able to promote health for everyone.
I love the fact that you brought up COVID-19, which is the tragic and devastating natural experiment of what happens when our public health systems are put under pressure in an environment in which they're not equipped to do what we would want them to do in ideal circumstances. But just to recap some of the things that you said that I think are really important, the fragmentation of services, especially for communities of color, having culturally appropriate services and trying to make sure that we combat bias in delivery and receipt of services is so important. And then ACEs, the adverse childhood experiences. I didn't know that term until my wife taught it to me. She works in K-12 education. So that's just something that I really think needs to be front and center, especially when we're thinking about juvenile justice, which is such an important part of this conversation around public safety, going back to what environments and experiences are children going through that prepare them for the future. A healthy environment creates a healthy future. An unhealthy environment in which we haven't invested creates an unhealthy future. Thanks so much for that, Dr. Gracia. Dr. Crifasi.
Yeah, I just wanted to raise one point for consideration, right? We're talking about public safety and creating safer communities, and we're also talking about mental health, behavioral health issues. And I just want to make sure, for those who are listening who may be less knowledgeable on the topic, that individuals who are experiencing a mental health issue or sort of have a mental health diagnosis are not more likely to be violent towards others. They're far more likely to harm themselves. But even if we were to get perfect mental health services for every individual who needed them, people who have a mental health issue are only responsible, sort of directly attributable to their mental health issue, for about 7% of interpersonal violence. And so I think it's just really important when we are talking about public safety and mental health and services that we really should be focused on trauma and victimization towards individuals who are experiencing a behavioral health crisis, and less concerned about them being the perpetrators of violence. That just, I think, continues to contribute to stigma around mental health. And so I just wanted to raise that so that when we're thinking about how we can make our communities safe and healthy, we aren't making it harder for people to feel empowered to receive services or to be open about any mental health challenges they may be having.
That is such an important point, that people with serious mental illnesses are not more likely to be violent, and that we need to focus on the trauma that they experience and intervene and try to interrupt that trauma and address it. Thank you so much for making that point and clarification, Dr. Crifasi. I want to talk a little bit about how, as public health professionals, each of you thinks that your industry, and I know there are different elements of public health in which each of you are expert, but how you generally think public health professionals should be engaging with our policy-making infrastructure and apparatus right now, because we're at this extraordinary generative time where effective grassroots organizing, particularly in the Black community, has raised up a possibility of moving into a new space, hence these conversations and hence the headlines that we're seeing throughout the country. But if we're going to move forward and craft solutions at a policy level that will bring about the ecosystem and holistic approach to public safety that includes a heavy emphasis on public health, then that's going to require expertise of folks like all of you. So I want to bring in Dr. LaVeist, if I can, and Dr. Zimmerman, just to give us some of their perspective on how you would see us changing the engagement between the public health profession and our policymakers and decision makers and elected leaders.
Absolutely. This is a vital question you're asking here. It is absolutely vital that public health professionals be engaged with policymakers, but that engagement must involve not only providing our expertise about what we know works or could potentially work to improve the health of communities, but also we need to understand how we can work with the policymakers to help them to frame those interventions in ways that are politically palatable, which helps give them cover that's necessary to be able to come out and advocate for these sorts of policies. Right now, in many parts of this country, if you want to get elected, the best way to do that is to gain the support of the police union, say that I'm going to increase the budget for policing and I'm going to crack down on those violent people living in that neighborhood over there where all the violence is happening, right? That we know is a often successful strategy for getting elected. We need to help policymakers to be able to craft different messages, and then we as voters, the community, need to be willing to respond to messages that talk more about investing in the creation of healthy communities rather than investing in cracking down on people that are who are engaging in behaviors that result from the lack of investment.
This is a critical point. David Kennedy said last week that even as we debate really important policy, that these are fundamentally political questions, and that they're always going to bump up against the water's edge of politics, and we try to bifurcate them, separate them, and that's a losing game. So the notion that the policy work that you do as public health professionals needs to be meshed and melded with the political work and advice to our elected and appointed decision makers and leaders is a really important headline for us right now. Thanks, Dr. LaVeist. Dr. Zimmerman.
What he said. But seriously, another angle on that is one of the things that some public health people are really good at is working with communities and working with the voters. Working with the constituencies and helping the constituencies have a voice in that process, so that we as public health experts are sort of facilitators of a voice of the community. There's this thing, you don't bring a knife to a gunfight. Well, you don't bring a gun to a mental health crisis. And that's the kind of message we need to kind of get out there. And I think people the people I work with in community, they know that already. So one thing we can do is try to help create opportunities for that voice to be heard. Another one that I like to think about is we have not been successful at stopping heart attacks by getting more ambulances out there and more EMT. We've deal with heart attacks by creating drug companies and cholesterol medications and blood pressure medications, but also behaviors. And creating opportunities for safer communities for people to walk and to interact in positive ways. And it's the same thing. The solution to violence isn't by bringing more police in. It's by thinking about what are the ways that we can do to prevent violence in the first place, and what are the root causes of violence. And I think as public health professionals, we focus on the root causes. We focus on the social determinants, as we talked about before. We talk about the multiple systems that have to come to bear to address these issues, and think about the economics and the education, and how helping policymakers see all of these connections so they can do the thing that Dr. LaVeist said regarding reframing the conversation. Because you're right, the low-hanging fruit, the easy thing is to say, I'm going to make you safe. And we're hearing it right now. I mean, it's happening today. There's some voices that are making the sense that the world is falling apart, and COVID notwithstanding, our cities are safe, our places, their people are living full and vibrant lives, and we're not focusing on that. We always are. We're focusing on the problems, and I think that's one way that public health can bring to bear the idea of promoting safety and engaging voice, community voice, and thinking about ways to study that is experimental and with rigorous methods.
Can I add one more thing to that?
Yeah, please.
That I think those of us in public health also need to look internally, because notwithstanding those of us that are on this webinar that I know are engaged in the political realm as well, public health has been hesitant to engage with policymakers, to engage with politics. I understand why. When politics meets science, science loses. I get it. But we do need to learn how we can engage in ways that can help policymakers to make better decisions, how help them to be able to incorporate these public health solutions into their policymaking.
I love that so much, because that is an easy line to draw that has significant consequences for the quality of the policy making that happens when we don't have public health professionals either willing to engage or meaningfully engaged by our elected and appointed officials. And to Dr. Zimmerman, I think concept of don't bring a gun to a mental health crisis is another thought that's going to linger, and I'm putting a star by that one. I want to bring in Dr. Gracia and Dr. Spivak to speak to the same question. Both of you have worked in the federal government, and you've been on the receiving end of questions, and you've asked questions and spent time thinking about how you manage the apparatus of our government in thinking through healthcare, health supports, health interventions, and public safety. So we'd love to get your perspectives on where you see opportunities for public health professionals to better and more effectively engage the administration, whether federal, state, or local, of our government. Dr. Gracia, if you could.
Certainly. Well, I think both Dr. LaVeist and Dr. Zimmerman raised really important points, and using that model too of how we can take policy to lead to systems change, to environmental changes, and then really impact population health more broadly, and not solely focused at the individual level, I think is very important so that we can see change. I think public health professionals certainly have a critical role to play, and many who are, but ongoing role really to focus too on in working with and educating policymakers is also advocating for what will lead to sustainable and scalable change. That we often grapple with is that there can be these investments that are short term, 2 to 3 years, and we're talking about issues that and inequities that are ingrained and embedded that date back decades, if not centuries, that we need to actually address and remedy as a nation. And so really working on issues systemically, but that can be sustained, and really making the argument of understanding and bringing that connection between public health and certainly the moral imperative that exists for everyone to have a fair and just opportunity for health, but also the economic imperative. When we look at cost, healthcare costs, the cost of a whole host of diseases that we may be addressing as a nation, where promoting health actually would be the more economically sound strategy for us as a country. I think that one of the things that we see, and we are in the midst, right, of a public health emergency that we often see in these types of disasters, is that there is a lot of national attention, there's a lot of policymaker attention, there's an influx and infusion of funds, but they're short term. And once the crisis has ended, and that investment also goes away. And it's the stops and starts of that really do a detriment to the communities that public health and all sectors are serving. And so it's how do we actually really lead to a long-term sustained investment? Some of the work that we're doing at Trust for America's Health is actually advocating for public health infrastructure, long-term sustained public health infrastructure, where there's an expert forum that has actually projected that we are having an annual budget shortfall of $4.5 billion in public health to be able to do the type of response, the communications, the community partnerships, the data surveillance that are necessary, not just to address one public health issue, but really a comprehensive and overarching public health framework.
Let me follow up on that with you, Dr. Gracia, because that's such an important point. Sustainable and scalable change, and the pursuit of investment that isn't just 1 year or 2 year or 3 year money, but resources that will allow a program to flourish, allow you to evaluate it, and then go forward with whatever adjustments are needed to make sure that the intervention is effective. It seems like an inherent tension, obviously, in all policymaking, but specifically with respect to public health. Well, what's the obstacle? And as you're tackling this and thinking about the programming that you're building and advocating for, what are some of the biggest hurdles that you have to overcome? Because I think for our viewing audience and for the conversation that we want to have, we really want to think practically about ways that we can galvanize support for the kind of work that you and the rest of our panelists are doing.
I think one of the challenges can often be, and you may see these types of stories in the news, is where public health professionals are often saying, many times people don't know what public health actually is, and that often is invisible, and that when public health is actually thriving and doing exactly what public health should be doing, your food is safe, the water is safe, children have access to immunizations, you have tobacco prevention programs. And so it may not be until a crisis that you see the role of public health, because it may seen to you behind the scenes and not as clearly evident as the role, and yet it's so essential, not only to the health and well-being of the nation, but really the economic vitality of the nation, as we see when we think about having healthy children who become healthy students and learners who then become the healthy workforce. And as we think about our aging population, we think about a diversifying population, all of these issues that promoting the health and well-being and equity of our country, that's also important to the vitality of our nation as well. I think another area is in thinking about the public health system, that sometimes the results and the outcomes are going to take time. And when you have either funding for a short period of time, or you have these cycles, whether they're election cycles or other types of cycles, to see the results, that you may not see the impact for beyond a 5 or 10 year period, but you can see incremental measures. And so it's also looking at how do we measure progress, because the investment is actually worth it. But sometimes there is a desire to see a reduction in a health outcome in a year's time, when recognizing that you actually need additional time and you need that sustained investment. The other may be too is that investing either in public health or investing in another sector may actually lead to the health outcome that you're desiring. Or, for example, if you're seeing increases in graduation rates, well, we know that there is a link between educational attainment and health outcomes. And so making that clear why public health and health really is in all policies, and that it's important to think about the public's health in that way and leading to that investment is something that public health professionals can really articulate. And I agree to Dr. LaVeist's point, do even more to really have that platform to be able to work with policymakers to make that case.
That is so helpful, because so much of what we want to avoid and try to get over in these conversations is just the diagnosis, and not get to what is the path forward, and the idea of public health being invisible until there's a crisis is that really sparked something in my mind. I think that's a really important concept for us to keep front and center. And the time that it takes to see an intervention through from inception to execution and evaluation is inconvenient to our political timetable. Back to Dr. LaVeist's point, that not only our policymakers, but also our residents and voters and citizens need to be able to understand that time that it takes and be okay with that as part of our process. That's really important. Thank you, Dr. Gracia. I want to bring in Dr. Spivak on this, if I could.
There's 2 points I actually want to make that I think are particularly important from a policy perspective. One is public health and medical care are not the same thing. And I think far too often policymakers see public health as medical care. Medical care is a system that's been built up primarily to treat disease. Public health is a much broader look at things that includes the treatment of disease, but gets far more into issues around social determinants of health and prevention and early identification and more upstream approaches to things, many of the things that Nadine was just talking about. And getting policymakers to understand that is extremely important, and a real point of frustration for a lot of public health people, because we invest an enormous amount of money in a healthcare system in this country, and yet our health indicators are not that great in comparison to other countries, in part because we've invested far less in public health and in the prevention and early identification and treatment of factors that can lead to more serious disease. So that's the first point. The second point I want to make is that public health people need to be willing to step out of our own silo and go into other sectors as well. I remember, again, giving a little historical perspective, I was invited to a White House conference when Janet Reno was the Attorney General, and she was talking to a room full of lawyers about child development. And there was this murmuring in the audience, what is she talking about? And the point that Janet Reno was making was that, again, understanding early childhood issues is an important component if the criminal justice system is going to deal with preventing crime rather than simply responding to crime. And quite frankly, one of the reasons I went to the National Institute of Justice and why I was actually in some ways recruited to the National Institute of Justice was to bring a public health perspective to the research that was being done in the Justice Department around criminal justice, because there was a recognition that there are public health approaches and strategies and a perspective that can actually add an important dimension to how criminal justice approaches problems and faces issues.
The distinction between public health and medical care, that's so very important, and that's something that resonates with me now, and I'm going to start to tease those out in these conversations. That thank you so much for raising that. And then the idea of getting comfortable in other spaces, this goes back to our ecosystem approach, that it seems like there is broad consensus that we need to do better in how we connect across systems and how we think about bringing sets of expertise to unique or different environments. We're going to keep digging in on that, but I do want to get Dr. Crifasi in on this question as well of what's the gap and how do you see the potential for public health interventions to be brought to bear in questions of public safety?
Yeah, first I just want to echo what Dr. Gracia and Dr. Spivak said about public health being invisible. So much happens related to public health and no one has any idea what it is until something goes wrong. And if folks haven't read it and they want to learn more about public health, you all should read While You Were Sleeping. It's a great book that summarizes public health successes. But I think when we think about how public health could benefit public safety, and as someone said, maybe Dr. LaVeist, I don't remember, said, public safety is really sort of a euphemism for policing. When we think about how public health could make substantive benefits in public safety, I really think of two specific areas. So I do a lot of work with law enforcement, and one of the things I've learned in my time working with law enforcement is that the way officers behave is largely driven by what is being tracked, right? So like what's being measured. If promotions are based on quantity, then officers are going to engage in behaviors that increase that quantity with perhaps little to no regard for quality, because there's very few feedback mechanisms in most law enforcement agencies. And so when we're talking about quality, when we're thinking about policing, we're really thinking about constitutionality, right? Are things fair? Are they applied equally? A great strength of public health is surveillance. We are really great at tracking things, at gathering data, measuring things. And I think public safety agencies, law enforcement would benefit from a robust public health support from public health professionals to generate some needed surveillance so that they can track quality. And this is going to lead to safer communities because you're going to be able to identify problem officers who need discipline or retraining. You're going to be able to track whether their programs or strategies that they're putting into place are effective. But I don't think it ends just with policing, right? Because public safety is much broader than just the police. And I think it was Dr. Gracia who mentioned that we do very little investment long-term in public health interventions to address violence. So if we take programs that I mentioned before, like Advanced Peace or Ready Chicago or ROCA, and we help to translate those programs into other communities, they might not be successful if they aren't resourced properly. And I think using the research models that we've developed in public health to create the evidence base to support these programs can help policymakers decide what to go for that's actually effective, rather than sort of just what might meet the needs or sort of gain attention in a particular moment. But we really need to focus on, at a minimum, 10 years of investment for any public health program. Dr. LaVeist raised the fact that we spend more in overtime in Baltimore City than for the police than we have for the health department, right? We throw money at policing like it's a bleeding wound, and if we just keep throwing money at it, then maybe something will happen. But when we think about investing in programs, we're like, you get 18 months of funding, that funding includes evaluation and you need to tell us 18 months from now if you reached your goals. That's not reasonable. And so I think public health professionals really need to advocate for sustained long-term funding to invest in these programs from a public health and community-based approach, as well as applying surveillance principles to improve the quality of policing.
That's incredibly helpful. The idea of a 10-year baseline for investing in public health interventions is so different from what we currently do. I think that's a really important marker to lay in the ground, and the need for better data and tracking and information. That's certainly a criminal justice principle that we spend a lot of time talking about, and the fact that our systems are fundamentally flawed, don't talk to each other. In the public health context, I imagine that is just as complicated. So I appreciated you raising that, Dr. Crifasi. I want to bring in Dr. LaVeist and Dr. Zimmerman just to follow up on this question of evidence and policymaking, because one of the tensions that we've seen over time is that we can devote resources to building the evidence base, and we can devote resources to the policymaking and engagement. But it seems to me that there is some tension between those two, and we haven't quite cracked the code on how we build them in. And Dr. LaVeist, you previously keyed in on the need for that expertise, and you all as experts who have that evidence to be able to inject that into our policymaking apparatus. Mm-hmm. This is a way of beginning the lightning round that we'll get to at the end. But what would you like to see if you had your druthers and were waving your magic wand when it comes to the relationship between the evidence base on public health interventions and public safety and how we do our policymaking? Like, how would you change that engagement?
Yeah, I mean, it would be spectacular if we could do that. But the problem is the 10-year time horizon that much of what we do requires exceeds the term of office of virtually every policymaker, right? So a successful mayor with 2 terms is going to be in there is going to get 8 years. And then any benefits that come from that investment that happened during that term in office is going to accrue to the successor. And I think this is an important and very, very real issue. I mean, I've had conversations with policymakers about this very issue, and in some cases, they've been willing to speak very openly about this. This is an issue. If we make this investment, it's not going to accrue to me. It's going to accrue to whoever is going to be in this office at some point in the future, and I need to get reelected. And these are some practical issues, and I think that those of us in public health, I think where the onus needs to be on us to work with policymakers to help them to be able to understand the importance of bringing an evidence base to policymaking, and how to help them to frame what they're doing in a way that can be politically supportive of their objectives, and get us to be able to be willing to make the investment in time and resources to make the kind of changes that we want to make. And I'll tell you, it's very difficult. I've had many of these conversations, and it's very hard to figure out how exactly to do that. And I can't say that I have a great answer, but I'm looking forward to hearing my colleagues on the panel maybe educate me on how to do it.
Well, I very much appreciate you raising it first and foremost, because in the words of James Baldwin, nothing that isn't faced can be changed, right? So the idea of the mismatch between the 10-year time horizon that you'd like to see for public health interventions to be tested, and then the relative terms of office for basically all public officials except maybe the FBI director, and those don't match up. And we need to figure out how to navigate that disconnect. Dr. Zimmerman, if I can get you in on this too.
Sure. Well, I mean, if we go back further, even, I mean, these are these issues that we're facing, and especially the race-related issues that we're facing, are centuries old. And to think that we can get this fixed in a year and a half or even a 5-year time frame is sort of silly, and I kind of agree. But we have to change the narrative is the bottom line. I find it really fascinating. A couple of things I find fascinating. One is that with all the policing that we've done over all the years, and with all the money we've thrown at policing, violence has abated a little bit, but we haven't eradicated it. So why are we continuing to do the same thing? I think it was Einstein who said the real mark of insanity is doing the same thing and expecting a different outcome. And I think we really have to rethink and reframe and redirect. So to me, it's like, I think we have to reframe the question and our approaches. We have to recover our communities. We have to focus on the strengths in those communities. We hear about, for example, do a lot of work in Flint, and we hear about the water crisis and this, that, and the other thing, and we hear a lot of negative things about Flint. But Flint has a rich history of community organizing and community engagement, and we need to take advantage of that, and we need to do that in ways that is sustainable and kind of maybe redirects some of our resources. So in terms of thinking, reframing, I always found it interesting that in the 80s and 90s, I think Dr. Gracia mentioned this, that we had a drug epidemic of heroin and cocaine, and it was called a war on drugs. We have a drug czar, right? But as soon as it became more of a problem, as soon as drugs became more of a white problem, it's an epidemic. And we throw millions and millions of dollars into it, and we throw it in ways that are not policing and not law enforcement. We throw it into medicine and prevention, naloxone, and training police to implement it. We do prevention. We're working with physicians on not using opioids like candy. We're talking about different programs that we do in schools. So we reframed it for that purpose. And honestly, we are making some inroads in the opium epidemic. We could do the same thing with violence if we had our minds to it. So I think one of our jobs, and you've heard some of the things that public health professionals do, but I think one of our jobs is to use evidence-based data to help drive and reframe the questions that we ask and how we ask them.
Two things you said there that are just massively important. Number one, taking advantage of community organizing and having public health be part of, as I mentioned before, that incredibly effective political work that is currently ongoing at a grassroots level. And then secondly, the difference between the criminalizing approach to the crack epidemic of the 80s and 90s, mostly for Black and brown bodies, versus a now healthcare approach to our opioids crisis, mostly for white folks, is a really important dynamic that we need to acknowledge and lift up as we think about how we move forward from here. So thank you so much for raising it. We only have a few minutes left, and this is raced by, and I want to do the lightning round question that I do at the end of each of these sessions, which is to turn to each of you, our distinguished panelists, and ask if you could wave your magic wand and have three things happen right now that you think would set us on a path to being able to define a new and generative and community-serving future of public safety. What would those three things be? And I'm going to start with Dr. Spivak.
Three things. One is a more holistic approach to how resources are distributed, looking at public safety in a broad way and not as a single dimensional issue. The second is I think there needs to be a huge shift in the culture in policing, and one where policing is invested in communities and not in solely in its authority. And the third is to really invest in communities and look at this as a community level issue and not simply a top-down approach to things.
Fantastic, thank you. Next up, Dr. Crifasi.
Yeah, I think you may hear some similar veins as you go through these three things, but I would say, number one, we need to really invest in community-based violence prevention programs that change social norms and provide wraparound services for individuals. We need to invest in communities. We need to stop disinvesting and start reinvesting in communities so that we can address the root causes of violence. But 1 and 2 are going to take time. And so 3 would be to implement robust tracking and accountability systems for policing to ensure that laws are being applied fairly and effectively to all communities and all individuals.
I love it. Next up, Dr. Zimmerman.
Okay. The first would be community voice. You're hearing that. I think getting community voice, thinking about the communities that are most affected by both policing, violence, and presence of violence, and have experienced a disproportionate outcomes relating to all of these issues, is having them be part of the solution rather than a focus on the problem. Secondly, I think you've heard this too, focus on community building, creating busy streets where people interact in positive ways, social capital is built, trust, neighborliness, and interacting in positive ways, and thinking beyond. And then last, well, the third one would be wishing for more wishes.
Isn't that usually against the rules when you run the genie lamp? You can't wish
exactly
for more
right. That's exactly right. But the third one is thinking ecologically. Thinking, we've heard that, we've heard this in different ways, but thinking ecologically, thinking about the multiple systems, the resources necessary, the interaction of systems, and thinking about how we can address this problem not from one specific perspective or another. So those would be my three.
Thank you so much. To Dr. LaVeist.
Well, not much meat left on the bone at this point.
You can get the gristle or the marrow if you want.
So I'm going to go in the direction of talking about narrative, change in narrative. Right now the dominant narrative is more police will result in less violence, and we need to put that lie to bed and talk about what would actually lead to less violence. Second is that we need policy making more infused with public health, and public health professionals need to be willing to get involved in doing that. And I guess the last narrative is that the narrative around the term defund police is a term that does not have strong political currency. We need to find a different way to message what we really mean, which is invest in healthy communities.
Fantastic. And Dr. Gracia, please take us out.
Absolutely. Just great suggestions from everyone. I would say one, given that this is such a grounding conversation in public health, is to invest in public health and invest in public health and social services and the infrastructure, because as we're asking public health to do more and more, the field is chronically underfunded, including a diminishing workforce that, especially in economic recessions, sees a great loss of its workforce. And we are seeing that now, certainly with the context of this pandemic. So one, investing in the public health infrastructure and social services that can help support communities. Two, I think mirroring what others have described with regards to addressing this long-standing disinvestment in communities and marginalization, especially of communities of color, is how we actually invest in and really get at the structural drivers that are creating these inequities in communities of color. They're creating disproportionate contact with criminal justice, but also addressing these other structural drivers of housing and education, employment, which I agree with Dr. Crifasi are not short-term policy solutions, but really, especially at this time of possibility for transformative change, we need to get at those root causes. And thirdly, and I think I agree with all of the comments here, I wanted to add this because we spent so much time in speaking of mental health and substance misuse. And lifting back up again, Dr. Crifasi's point that it's not that individuals who have mental illness or substance use that are more violent, that they're disproportionately being impacted in the criminal justice system, is for us to move upstream in prevention and actually focus on the full continuum of prevention, treatment, and recovery for those who are suffering from mental illness and substance use disorder, because it's not a moral failing. It is something that we need to address as a public health issue and crisis that it is.
That continuum of care is a perfect way to close out this conversation. I want to say thank you to Dr. Gracia, Dr. LaVeist, Dr. Spivak, Dr. Crifasi, and Dr. Zimmerman for your time today. Your perspective is invaluable to this conversation on where we go in the future of public safety. I'm just so excited to have been able to talk to you for the past hour and a half, and I wish we had time for more, but certainly look forward to the next. And to our viewing audience, this brings us to the end of today's conversation. We have 2 more left in this series, and I trust that they are going to be just as generative when it comes to thinking through the next steps that we can all take practically to capture and define a new future of public safety and think more broadly about the ecosystem of safety as we move forward together in our communities across the country. Thanks so much for being with us. As always, please keep your questions and thoughts and ideas coming, and we'll endeavor to include them in the next session. Look forward to the next. Take care.